back for episode 3 today. As many of you know, or if you've watched the previous two podcasts where I talked about my sepsis survival story that resulted from undiagnosed diverticulitis that led to a colon perforation that led to me developing septic shock and needing a helicopter ride to shock trauma in Baltimore to save my life. I'm hosting this podcast to help inform people about what sepsis is, how to diagnose it quickly, how to recognize it, infection prevention, and all kinds of things that also interrelate with our chronic illness and our disability community, and talk about all the issues involving all of that. I look forward to a very long run with this podcast because, as we all know, there are so many issues to touch upon with any of these three things, with sepsis, chronic illness, or disability. Today, I am so excited to welcome as my first inaugural guest on episode 3, titled What is Sepsis?, Dr. Karin Molander. Now, Dr. Karin Molander, also, she is an emergency room physician with over 20 years in the Sutter healthcare system in the San Francisco Bay Area. I had the wonderful opportunity to interview her for my story that appeared last year in the Healthy at the Reader's Digest website online when I talked about my sepsis survival story, and I was able to interview Dr. Molander for that. And so here I'm going to have her back here today as our first guest to explain what sepsis is, how it develops, what infection prevention is, and how it relates to sepsis, and why infection prevention is so important. Now, Dr. Molander, as I explained, she is an emergency room physician, over 20 years experience in the Sutter healthcare system, and over 25 years collective experience as an ER physician. She has also been immersed in the world of sepsis since 2007. She has served on her hospital's sepsis committees from 2009 to 2015. She has trained intensivists and collaborated with fellow Sutter hospitals as they navigated new sepsis initiatives to optimize patient care in these life and death situations. Dr. Molander has also served on the Sepsis Alliance Board, of which I am an advisory board member. She has served on the Sepsis Alliance Board since 2018 and was recently their chair of the board of directors. She has also co-authored a whole chapter on sepsis for the American Medical Life Support Textbook for Emergency Medical Services and has had an updated edition coming out later this year. Dr. Molander is currently participating in a year-long digital health fellowship with the goal of optimizing communication amongst patients and providers. Now, I just want to remind viewers that this podcast is for information purposes only. It is not intended, never intended as medical advice. So if you have an infection or other medical issue, please contact your physician or go to your local emergency room. So without much more ado, I want to start by introducing Dr. Molander and start to have this conversation, this very important conversation on what is sepsis. On today to the podcast. I'm very excited to have you here with your area of unique experience, both personally and professionally, with sepsis. I couldn't wait to have you on the podcast to let our listeners and our viewers know that golden question, what is sepsis? Because it's often what I hear most often when I'm talking about sepsis in the community. There is a lot of questioning about what it actually is, and people are trying to understand it better. So if we could,
Yes.
just start off with that question. And thank you again for being here, Dr. Molander.
Oh, Jackie, it's such a pleasure. I really enjoy spending time with you. And I think you're serving an extremely important role because one of the challenges that we face in medicine is that what we use as a definition of sepsis can be very different from the mindset of the average community member as to what sepsis is. The easiest way that I'd like to think about it is that it's our body's overwhelming response to an infection. And it's what we call a clinical diagnosis. So we have no perfect test that says, oh yeah, this is sepsis. No blood test, no EKG, for example, no CAT scan that says, oh, this is obviously a case of sepsis. So, what we do in the medical community is we look at what we call a constellation of symptoms and signs. Um, we look at a patient's vital signs to see if they look abnormal. We look to see if, first of all, you have an infection, because if you don't have an infection, you can't have sepsis. And that's why one of the things that we talk about at Sepsis Alliance is that infection prevention is sepsis prevention. So in the emergency department, when I'm contemplating, does this person have sepsis or not, is first of all, I'm trying to see, do they have a sign of an infection somewhere, urinary tract infection, pneumonia? And oftentimes, I don't know. The person's just confused coming in. They can have a temperature that's super high or super low. Those are the really challenging cases. We forget that a low body temperature or no temperature at all, and you can still have sepsis. And then we look for whether the patient is so sick that we're seeing signs that organs have been damaged. And the way to think about it is that their immune system, rather than just going after that nasty little scratch on their arm, has caused them to all of a sudden have a dangerously high heart rate, dangerously low blood pressure, and has caused their kidneys to be affected in how well they function, or has caused them to have a low oxygen level, letting me know that their lungs have been affected. So those would be some examples. If you don't mind me mentioning, there are blood tests that we also look for to see about. So you're probably familiar with what we call a CBC, or a complete blood count. Okay, so that is something that shows your white blood cell count, your red blood cells, and your platelets. And sometimes when people have an infection, their white blood cell count can again be very high or very low. And we also look for a certain pattern of which of those white blood cells are high. So you might hear a physician or a nurse or someone in the medical community mention bands. And that is a type of immature white blood cell that is saying that your bone marrow is ramping up and saying, I need to get more of these killer white blood cells out there to go fight this infection. So they'll say something like, the neutrophil count is high, or the patient has a high band count. So that's one thing that we look for, which sometimes can take a while to get back from the lab. So we also look for other blood tests. There's a blood test called lactate, or lactic acid. And people who are athletes might use the word lactic acid or lactate to talk about their blood level after they've run a marathon, or, Lance Armstrong after he was doing the Tour de France. They're monitoring how much work the body is doing when there is low oxygen level. So what we call our anaerobic state. And oftentimes when someone has a sepsis, they're not only working in their aerobic or oxygen heavy state, but their body is under such duress. It has such poor blood flow to the tiny little blood vessels in the tips of the fingers, or in any of the end organs, brain, heart, lungs, kidneys, that it causes that lactic acid level to be elevated. Now, if you heard me mentioning that it can also be elevated with athletes, that's the challenge that physicians face. Is it's a very imperfect test. It can be elevated in athletes after they've run a marathon. It can be elevated in people who have livers that don't process lactate as well. So someone with poor liver function can have a chronically elevated lactic acid level. So there are many other states that can cause someone to have an elevated lactic acid level. And yet we're using this imperfect marker at this time because it's something that we have seen in a person who has sepsis, who has an elevated lactic acid level. If we are able to normalize it quickly, they have a much higher likelihood of surviving to discharge home. So it's not necessarily the most perfect test, but it is a measure that currently hospitals are asked to look at.
Thank you so much, Dr. Molander, for explaining that, especially the lactic part, because I've heard that at conferences, and I've heard other doctors discuss it when they're talking about septic shock or sepsis. Does lactate has something to do with muscle function, does it?
So, it has something to do with everything function. So, if you're asking me to pull up stuff from my organic chem and biochem days, but it's part of the kind of the Krebs cycle. So, as your mitochondria are trying to provide energy to your body, if you are not getting enough oxygen to those areas, you go into an anaerobic state, and that causes lactic acid to build up. And the challenge is there's so many other things that can go wrong in that process that for example, it can be elevated in trauma as well. And in my humble opinion, the reason that we've used lactic acid for so many years is this was a test that was readily available in every hospital across the US in the 90s when I was first training. And we used it quite frequently to assess trauma patients and to figure out, okay, how sick is this trauma patient? And anecdotally, out of some of the work coming out of Detroit Receiving Hospital, Emmanuel Rivers, and Bryant Nguyen he is out of Loma Linda University. They saw that in patients with sepsis, that if someone had a very high lactic acid level, they had a very high risk of death. And so it was an easy lab test to institute because it was already there at hospitals across the US. And so it wasn't a stretch to do that. And unfortunately, you know, sepsis is one of the most challenging things for us to diagnose. We have this saying that says when, sepsis or septic shock is easy to diagnose, it's difficult to treat. And when it's difficult to diagnose, it's easy to treat because the earlier we're able to catch it, and give those appropriate antibiotics and give IV fluid resuscitation and watch the patient more carefully, most importantly, we find that their survival rate is much higher. And because we lack that perfect tool to that perfect lab test, my goodness, 30, 40, 50 years ago, trying to diagnose an acute heart attack, you would get the guy coming in holding his chest and saying he's having horrible chest pain, and then you would get an EKG. And in, the past 30, 40 years, we've been able to develop lab tests that can look quite closely at whether there has been heart damage. And one of those lab tests is a lab test called troponin. And we're able to see that and say, oh, yes, we've got to keep a close watch on this person. We're seeing evidence of heart damage due to poor blood flow to a portion of the heart. We still don't yet have that perfect diagnostic study. And because sepsis can appear so differently depending upon a patient's chronic medical conditions or their age, it can be very difficult to find. For example, in a newborn child, you may only have the sign that they're having poor feeding, or they're not holding their head up as well, or they're not urinating as frequently, or their muscle tone is poor. And because a newborn child can't say, "Oh, mom, my bladder hurts. I have a urinary tract infection." They don't have that capability. So whenever we're thinking about populations that have a challenge with communication, they are at a higher risk of sepsis. So that would be the very young and the very old, where that communication gap exists, and also where their immune system is not fully functional, guns a-blazing. So those are two risk groups that are at much higher risk of sepsis, but anybody can get it.
Right. That's right. And you have this whole wide population of people who at any time, any infection could develop sepsis. And
And
time to have the right
statistically,
diagnostics. I mean, I think that's why it's important with the lactic acid then to remember that test being accessible at all
mhm,
hospitals, because oftentimes when I give a presentation, I tell people that I think I survived also because of my geography and where I live in central Maryland. And they were able to fly me immediately to the trauma center in Baltimore and get me there quickly, and they were able to diagnose it quickly. But some other like smaller hospitals might not have the capability to have other kinds of tests. So I think that is important, you mentioning that lactic acid is something that can be checked through the blood work, right? They get,
yes,
it's a lab test, so just draw some
right.
blood and run it through the lab, and the result comes back rather quickly, doesn't it? With
Yes,
lactic acid. Okay.
yes. For example, one of the other tests that we get when we are concerned about sepsis, so first of all, you have to suspect sepsis. So if someone's coming in who's confused, obviously I want to be concerned about the possibility of stroke. I want to be concerned about them having an electrolyte abnormality, for example, a low salt level. But you also have to have in that back of your mind, could this possibly be sepsis? You know, um, I think one of the other things to remember about sepsis is that it's super common. 49 million cases worldwide per year,
Yes.
1.7 million cases in the United States, and 350,000 patients per year die of sepsis. And I think one of the key things to think about, especially in the data that we see in patients who are over age 65, okay? If you have a bout of sepsis, when you leave the hospital, you are likely to have lost 1.7, what we call activities of daily living. And now, those activities of daily living, it just means what you need to do to function on a regular basis. Can you feed yourself? Can you toilet yourself? Can you control your bowel or your bladder? Can you move from your bed to standing upright? Can you move from your bed to the toilet? Um, and then, why am I thinking about number six? Oh, and then can you feed yourself and dress yourself? So 1.7 of those are likely to be gone when you leave the hospital. So knowing the best way to survive sepsis is to never get it. Again, infection prevention is sepsis prevention.
Right.
Um, so the other thing is definitely knowing that any human being is at risk. So Jackie, maybe I should tell about my story of having sepsis because
That's the perfect segue, Dr. Molander. I
so
was heading in that direction because, yeah, listeners are going to be surprised to hear that, yes, doctors can develop sepsis too.
so I think the key thing is, doctors have a little bit of hubris. We normally think we take pretty good care of ourselves. And yet when I was pregnant with my oldest child, I had been laboring for a number of days and started to just have this uncontrollable urge to move, like shaking all over the place. And, despite, delivering multiple babies in my, young career at that point, and, despite the fact that I had two friends in the room with me that were also physicians, you know, um, despite all of that, I'm sitting there thinking, oh, maybe I'm having a big adrenaline rush. Maybe the tyke is finally on the way. And then I'm realizing that I'm trying to get up and move around and wanting extra blankets. And it was the really smart, sage labor and delivery nurse who comes in and she's like, maybe I should check your temperature. And she checks my temperature and it's 103. And she notifies the cavalry, and I had to, and I get immediate antibiotics, I get immediate IV fluids. And my blood pressure improved, my heart rate improved. and I was able to deliver my child, but my child had very low APGAR scores and required pretty extensive resuscitation and had to spend the first 3 days of his life in the neonatal intensive care unit. And he's fine now. He's a very healthy 25-year-old living on his own. But it was terrifying. And I think it was humbling for me to realize, even though I was a healthy marathon runner, I wasn't on any chronic medications. Um, the stress of just being a pregnant woman, because you do have changes in your ability to fight infection when you're pregnant. You're growing what we call this cute little friendly parasite in your placenta, but you don't want to have an overwhelming immune response to that cute little critter. So your immune system does have to adapt during pregnancy, and you are at higher risk. You even have a change in your breathing pattern because the belly is pushed up, and so you're not taking deep enough breaths. So that could put you at risk of developing infection. So it's definitely humbling yet challenging. So how do people prepare for that? Definitely trying to stay healthy, getting out and getting exercise as best you can every day. Um, the issue is that there's certain populations that will be at higher risk of infection and therefore sepsis. So, for example, the person who has diabetes, one of the challenges with diabetes is that it can affect the sensation in the tips of your hands and the tips of your toes in your feet. And as you start losing the ability to feel, you're at higher risk of stepping on an errant piece of wood or stepping on a nail and having an infection brew in the bottom of your foot without even realizing it, which is why it's important, for example, that a diabetic check their feet twice a day, you know. And then you think about all these folks who are doing very well with management of their psoriasis or their lupus, but they're on a once a month injection. And that psoriasis and lupus are both illnesses where, again, your body is overreacting to itself. So the way that those medications work, those monthly medications, is they suppress your immune system to stop fighting itself. Okay. But it's not smart enough just to suppress the immune system against fighting itself. It also puts you at risk of infection. And I think sometimes folks who are just so happy to have all those dry patches from their psoriasis gone, they fail to mention that once a month injectable is putting them at risk of infection. And so that's something to think about. Yeah.
And something we should know too to clarify with our doctors, because with
Yeah.
my conditions, I was on high dose prednisone when I went into septic shock, and I developed that diverticulitis in my colon, which led to the perforation. And
Yeah.
the doctors did caution me while I was on the steroids, saying, try not to get sick. And it was during the height of COVID, so I naturally assumed they meant, oh, don't get COVID, be careful, don't get a cold. Never did I imagine being flown to a trauma center for emergency surgery and developing septic shock.
Right.
I mean, I would have
Oh
liked
my
to have had
gosh.
sepsis just one time in the course of that. But Dr. Molander, you bring up an important point too that a lot of people do not realize, that sepsis is the second leading cause of maternal mortality, and you developed sepsis when you were in delivery. And and you did touch on this already about, a woman's immune system being lowered so that, it doesn't fight off the little parasite. but
Friendly parasite.
yes, yeah, the little traveler in there, or foreigner. So,
Right.
but so are there other reasons also, like are women who are pregnant more susceptible to develop infection in general?
Well, I think the key thing is, It's more difficult to diagnose appendicitis in the pregnant woman because everything shifts in there. You got to make room for that beautiful baby. Um, the other issue is you're putting a lot of pressure on your bladder, and sometimes people have difficulty emptying their bladder as the baby grows in the lower pelvis. Um, Sometimes you deal with a joy and challenge of constipation, which can put you at risk for developing a urinary tract infection. And any age range. So that can happen as well as the bacteria translocate across the rectum right over to the bladder and say hello. You know, we are wonderful walking petri dishes. We have more bacterial cells and viral cells in us than we have human cells. And they serve a lovely purpose when they're in their right location, you know, maybe producing a little bit of acid on our skin so that we have less risk of infection, or maybe helping us digest our food and our intestines. But when that E. coli that normally hangs out in our intestines decides it no longer just wants to stay there and help us digest our food, and it ends up in our bladder because the exit point for both your bladder and your bowel are just a short distance apart, it puts you at higher risk of an infection because E. coli does not belong in your bladder, you know? Um, I think that that is one of the key things for people to remember. Yeah.
And the number one infection, the most likely cause of sepsis, is it UTIs?
Good question. I'd have to look at the literature, but I'm pretty darn near positive. You know, the top three are, you know, pneumonia, lung infections. I think that's number two. I think urinary tract infections and abdominal infections. And then skin infections are another common cause. I think the key thing to realize is that this is more common than people realize. 87% of cases of sepsis occur in the community, meaning they start in the home. Only 13% of sepsis cases are what we call contracted in the hospital. And yet it's the number one killer in hospitals, and it's the number one cost to hospitals. So this is a very big problem, which is why we've had this kind of Medicare and Medicaid, Centers for Medicare and Medicaid have said that every hospital should be looking at this. And the way that they've been currently watching it is something called SEP 1. And what that is telling hospitals across the United States, it doesn't matter if you're in Baton Rouge, Louisiana, Baltimore, Maryland, or San Francisco, California. It's saying that if you suspect sepsis in a patient, that you should draw a lactic acid, like we talked about earlier, blood cultures, two sets of blood cultures, that you should give IV fluids if the patient is in need of that, and most importantly, get rapid broad spectrum antibiotics started. So those are the key things, and because it's setting that mark and telling the clinicians, the nurses, the patients, the physicians, the NPs, everybody who's on that treatment team. And I'm saying patients because you're a part of the treatment team. So is your family, you know. It's telling us, like, look, we better recheck that patient 3 hours out and have another lactic acid drawn, because again, we talked about how lactate clearance is a very good indicator of whether you're on the right track of helping that person that you suspected sepsis of. And then it's also asking, how does the person look clinically? Is there, you know, get a complete set of vital signs. Is their temperature better? Is their heart rate better? Is their blood pressure better? Is their oxygen saturation better? And how do they clinically feel? You know, it's saying, let's get back to the bedside and do another check. Obviously, if someone is even more ill with septic shock, which indicates a very high lactic acid level, and it's saying that you should be looked or considered for septic shock if you have a low blood pressure,
Yes.
okay, that has not responded to IV fluids, or if you have an elevated lactic acid level. And again, it's saying to look back and check again. And monitor that blood pressure more frequently and quickly give patients blood pressure medicines to help their blood pressure so we can perfuse these end organs, the brain, the lungs, the kidneys, the tips of the fingers, the tips of um, the toes. The challenge is that with some of these vasopressors, it's going to um, uh, cause the smaller blood vessels to be compromised because it's focusing on shunting blood to the brain, the heart, the abdomen. Um,
Like
so
everything in
that's
this area, in the core.
exactly,
Yes.
exactly. So that's definitely something why we have to monitor these patients so closely. Yeah.
Is that also why some sepsis survivors have to have amputations?
Yes. I one of the challenges with septic shock is that the blood vessels all over the body can get what we call quite leaky, and they're unable to clamp down in response to the infection that you're having. And you can develop something called DIC, or disseminated intravascular coagulation, where at the same time that you're leaking fluid, so they can get really puffy and swollen. You also are causing clots to happen in the littlest blood vessels, and it puts those tips at risk. You know, and it's this balance. Why aren't we just giving every patient who's confused antibiotics when they come into the emergency department? Hey, let's just give them a dose. Well, part of it is because we're trying to avoid something called AMR,
Yes.
or antimicrobial resistance.
Another
And
big concern in our sepsis community.
right. It's really a challenge when someone eh, these little critters, they've been around for millennia, these little bacteria, these little one-celled units. And so they've gotten pretty smart at outwitting a lot of the antibiotics that we have around. Some of our oldest antibiotics, like penicillin, which was found in the 30s along with sulfa drugs, they've been around so long that some of these bacteria have learned how to be resistant to penicillin based medications. So you might hear the word MRSA, or methicillin resistant Staph aureus. Okay. And Staph aureus is a common bacteria that's on your skin, it's on my skin. It's just hanging out, doing its own thing, and typically doesn't cause a problem for us unless we have a cut in our skin from gardening, or we have an inflamed hair follicle from a bad job shaving, or whatever the case may be, or using uh, dirty weightlifting equipment at the gym, where maybe they're not cleaning it as well as we would like. So then that bacteria, the MRSA, can decide to go ahead and head in. And if you give someone methicillin, which is kind of a cousin or sister to penicillin, it won't work against this Staph aureus, when for years it worked. And so we've had to come up with other antibiotics to try and help fight that infection. And that's an example of a bacteria that has developed AMR, or antimicrobial resistance.
Right. It's like the longer they are around these bacteria, the tougher they get. I mean,
Right,
it's
right.
incredible and amazing to imagine that, yes, these simple little organisms can learn and they can learn
Oh, they
how to
can.
evade the
Right.
antibiotics. I guess, their
Yeah.
survival instinct must be really high. But that's
Yeah.
that's what, a lot of people, when you mention the gym equipment, because I do go to the gym and I do
Way to
use those
go.
wipes.
Do
If we're going to
yes.
talk infection prevention, it's really good to know. Use those wipes. All those wipes are all over all the gyms and everywhere. And I do, because I know people have wiped them off before me, but I give it an extra wipe when I go to use that equipment, because you can't be too careful, I think, when it
Right.
comes to
Well, luck
commonly
favors a
used
prepared
things.
mind.
Yes.
luck favors a prepared mind, as Louis Pasteur said. It's kind of funny. You talk about like the 5 second rule if someone drops some food on the ground or um, it's surprising to see where these microbes can hide. Whether it be, the nurse's stethoscope or, the tray in the on your airline seat. I think, being careful is important. And, there's certain steps we can take, like wiping down the gym equipment. One of the most important anti-aging things that you can do for yourself, one of the most important ways to boost up your immune system is regular exercise. And then let's throw in sleep there. You know, if you allow your body to have that period of sleep, that is also extremely important to maintaining your immune system. And regular exercise, very good. That's super important to do.
Right. Yes, good points. And we don't want everybody to become a germaphobe here, be
Right,
afraid to
right.
touch
Yeah,
anything, that's commonly used. But I always think of it like have good judgment. If you are in
right.
an airline where a lot of people have been sitting in that seat, it might be a good idea to just take out your little wipes and just give your tray a little, but you don't have to go crazy over it, right?
Right, right. And I think the other thing is, you know, if you're trying to make it out to see your family for Christmas and you've got a cold,
Mhm.
be courteous. Wear a mask around others while you're on the airplane. Because you wearing a mask is going to do a lot more to help everybody else who's also taking that lovely trip to go see family than having everybody around you wear a mask while you know, ah, ah, ah.
Yeah.
you know,
Yes.
the it unfortunately, one of the things that I've noticed is that people are co not covering their cough as much as they were in 2020, 2021. And that is another kind thing you could do to your neighbor is just to cover your
Yeah.
cough with your elbow. I always, tell the cute little kids who come into the emergency department with their cold, I'm like, it's a superhero swipe,
Yeah.
you're taking your cape and covering your mouth like Batman, just trying to tell them like this is one of the things you can do to keep your mom, dad, brother, sister, grandma, grandpa safe while you're trying to feel better, you
Absolutely.
know?
So,
Yeah.
as you said, sepsis prevention is infection prevention, which is, a
Yeah.
lot of what we've just been discussing. And, just common sense things like, yes, wear a mask. I mean, when my daughters got COVID and my husband and I hadn't had it yet, they were in the home with us, but we all masked. And
Yeah.
if I took
Yeah.
the food in, had the mask on, came out, washed my hands very good, and not just a quick wash, but a real wash with some soap and warm water.
Right. Do happy birthday. You sing happy birthday 2 times in a row while you're washing your hands. Make sure that you're getting underneath your nails, the whole 9 yards. Especially if you know you're going to be around someone who's sick. So if you're having to take care of a sick family member, definitely pausing a moment. It's also a great opportunity to meditate, you know, use it as your meditative practice. Allow yourself to take some time and do some uh, deep breathing exercises to help bring the heart rate down, bring the blood pressure down, because it's stressful to take care of a family member.
Yes,
You want to try and help yourself and your immune system if you're having to do that.
yes, yes, and yes. So, even in the best of instances, we could be as careful as we can be,
Right.
and we can still develop an infection and still develop sepsis. So, if you think you're how is it that someone with an infection might know that they need medical attention right away?
So I think one of the key things is recognizing anybody can get sepsis. And also, if you have, for example, an infection on your skin or what we call a cellulitis, one of the things to do is, to monitor, first of all, what are your vital signs? Because the thing is that what might be a regular heart rate for me, 55, might be dangerously low for you. So knowing what your normal vital signs are. I mean, everybody is having wearables these days. Yeah. So I think knowing what your normal vital signs are, and having a thermometer in the home is nice to add to your little first aid kit. No, it's not a perfect tool because, like we talked about earlier, you can still have sepsis even if your temperature is normal or low. Um, so the other thing is it's so helpful to have someone who knows you who can say, "Wow, Jackie's acting kind of confused. Is she okay? Let me check her vital signs. So having someone check in on you if you are dealing with a bad pneumonia, but you're still healthy enough to go home, it on Amazon you can get an oxygen saturation monitor for like $20. So having that kit there, if you're dealing with a lung infection, so that you can monitor to see if your vital signs are normal or not. And it's always good to have a sense of what your vital signs are normally, like walking around healthy, that kind of thing. And then when you're sick, trying to monitor if things change. I think the key thing is if someone's heart rate is going through the roof, which unfortunately can happen if they're anxious about their infection, but trying to work on those nice exercises that we do to try and help bring the anxiety level down. But also knowing what the blood pressure is and also looking at the wound. If the area of redness is getting worse, or if they're seeing red streaks going up the arm into the armpit, so those are various things that you can look at. And we, people most likely do not have the ability to check blood work. So it's okay to say, call your doctor. I'm concerned about sepsis because of X, Y, Z. And then the doctor may say, oh, okay, with those vital signs, they still look okay. Maybe we should get some blood work done. And then they might be apt to check that white blood cell count. Or maybe they'll check the chest x-ray again, for example, if it's an infection in the lungs, or they'll say, hey, can you come to my clinic so I can just look at you? Because again, one of the challenges that we face in medicine is it is a clinical diagnosis. We're looking at the patient. We're trying to see, is their skin color okay? What are their vital signs looking like? So it's putting all these pieces of the puzzle together. Uh, and sometimes one of the challenges that we face is, this doctor who's known us for 15 years doesn't have a clinic appointment and they say, go to the emergency department or go to the urgent care clinic. And unfortunately, Dr. Jones or Dr. Smith or doesn't know you in the emergency department as well as your primary care physician.
Right.
And that's when I think it's super important that the patient bring a patient advocate with them. Because sometimes when you're in the overwhelming situation of dealing with your own illness and presenting, sometimes it's hard for you to voice the reasons why you are so concerned. You're kind of overwhelmed with the diagnosis. You're overwhelmed with the questions about, medications and allergies, and why are they asking me about my allergies for the third time? And it's because we don't want to give you something you're allergic to. So there's a reason we do that. Um,
Yes.
uh, and it's so important to get the perspective of someone who knows you when you are healthy,
Right.
so they can say, Jackie is acting very friendly to you. She is able to crack all these jokes, but she couldn't get out of bed this morning. She's putting on a good veneer for you right now in this room because she doesn't want to be here in the ER. She wants to go home because she knows that she has her dog that she needs to take care of. So it helps to have that outside perspective of another person there. Now, let's say you're in the emergency department and they say, "Oh, you look great. We're going to send you home." But you're still sitting there like, "Oh my God, how do they know I don't have sepsis?" And I think it's okay to ask the clinician, like, okay, can you help me understand why you don't think I have sepsis? Number one. And then also clarifying that what would be the signs and symptoms that I need to watch out for that would say I need to come back to my primary care physician, to the urgent care, to the emergency department. And, gosh, it would be great if I had this little magic ball that would tell me if someone's going to have a
Right.
successful management of their cellulitis or their pneumonia with antibiotics that I've given them. But the key thing is knowing when they should escalate.
Yes.
Yeah, yeah.
But,
And if you're, and I think the key thing is if you feel like the story that the clinician is giving you, like, oh, you're fine, you're fine, you're fine. Um, I think it's important to have them reiterate, okay, I need some reassurance. Can you tell me what makes you so certain that that I'm in an okay state right now? And I think sometimes kind of slowing that roll
Mhm.
helps. And I think also mentioning, for example, I almost died of sepsis a month ago.
Right.
And this is a big concern for me because of that.
Yes.
And I need some reassurance, but I'd also like you to understand that because I was being treated over at Hospital A. So you may not be aware that I just survived this horrible case of sepsis, or I think the other key thing is when someone's confused, it's so helpful to have someone else who knows that individual with them. If we see a diagnosis of, for example, dementia on someone's chart, someone can have some pretty mild dementia and still be doing the New York Times crossword puzzle on Wednesday and Thursday without a glitch. It's early, mild cognitive delay. But if they have that diagnosis of dementia, sometimes it's easy for the clinician to disregard. And you have to say, look, you know, this person has mild cognitive delay, but they're still doing the New York Times puzzle on Wednesday or Thursday until this morning. And then this morning, they couldn't even put their t shirt on correctly. So, trying to explain how that person is different from before. Those are
That's
the key things.
excellent. Excellent key points, Dr. Molander, because I know just even within my chronic illness community, people with POTS tend to have
Uh
low
huh.
blood pressure and high heart rates
Yes.
anyway. And when you said know your vitals, people really need to have like an idea of what their baseline is. And if they're dealing with a relative, as you just stated, with someone who has dementia, know what their normal is, so to speak.
Right.
Because dementia, yes, they could have certain behaviors that they do because of the cognitive decline, but if they're really sick, that person would know that their loved one is acting differently and, needs to communicate that to their doctor, correct?
Yes. And you're bringing up a really important point about POTS and also because I know you so well.
Yes.
Um, for example, your diagnosis of Ehlers-Danlos.
Yes.
I think sometimes, you know, sometimes the patient with these chronic rare illnesses knows more about their illness than the clinicians who are standing in front of them. We all had to go through training, you know, um, and we're learning more and more about POTS and Ehlers-Danlos, for example, than we did 5 years ago, 10 years ago. And I think one of the key things is explaining to these clinicians, I have Ehlers-Danlos, and when I have had infection in the past, this is how it manifests itself. When I've had POTS, episodes in the past, this is how it manifests itself. And today is different.
Mhm.
And these are the ways it's different. And this is why my concern level is higher. Sometimes when patients come in the emergency department, things are happening so fast and furious,
Mhm.
you know, um, that they sometimes don't have the ability to say, look, this is the worst I've ever felt.
Right.
or um, uh, she's not quite right. I feel unsafe taking her home. You know, she cannot walk. She lives alone. All these things where you're already, as the loved one or the person who is with this person, um, it's important for you to be present in the emergency department so that these little kind of slips through the cracks don't happen. And one of the other things you can do, if you're still, they're saying, look, really, everything looks great right now, we're not seeing any signs of sepsis, is line up a follow-up appointment. Say, line up a follow-up appointment with your primary care doctor, with the urgent care. Um, I don't think I'd want to come back to the emergency department and wait there for another 8 hours the following day, so it'd be nice if someone could help you out with that. So, um, and the other thing is making sure if you leave that emergency department that someone gets you the antibiotics from the pharmacy, that, so I've had cases where I've started antibiotics and taking care of the patient in the emergency department, and then they decide to go home and sleep it off,
Mhm.
and they fail to pick up the antibiotics because the pharmacy closed for the weekend, or and it's like, oh my gosh, why didn't you tell me that you needed it sent to a 24-hour pharmacy, or that someone couldn't get the antibiotic for you. So little steps like that also are important to make sure that the patient um, uh, you know, has the antibiotics in their hand, within the next few hours, you know.
Treating sepsis and diagnosing sepsis really sounds like a big teamwork effort on the part of all of you providers and the patient and their loved ones.
Yes. One of the sayings that I say all the time is teamwork makes the dream work. And, I think the other tool that patients and loved ones can use is, if they're meeting resistance, is saying, I think we're all on the same team here. We want this patient to get better, right? Help me learn how to help you to keep this patient healthier, or to help this patient come back to health. And I think um, sometimes in the stress and the hubbub of the emergency department, and seeing a full waiting room, and the hallways lined up with gurneys, it's pretty easy to kind of um, be maybe a little bit too curt in trying to explain what's going on. And also, if you feel like you're not getting the answers or understanding what sepsis is, go to the website, for our humble nonprofit, Sepsis Alliance, sepsis.org, because it does have very effective tools for, or brochures, stories of sepsis, and there's things to expect after discharge from the hospital. There's a pamphlet for loved ones of someone who has suffered from sepsis. There's pamphlets that talk about post-sepsis syndrome, for example. Why is your loved one still so foggy brained even after they finished all the antibiotics?
Or crying
Why are
every
they
day.
so right? Right. I think knowing that you're not alone is a really important process too, so taking advantage of the free resources on Sepsis Alliance, so that these sepsis survivors can connect with other sepsis survivors, and thus the name Sepsis Connect.
Well, I am so glad. I was just getting to that point too, to ask you, if we could tell people to go to sepsis.org. And I will have them linked too in my description for this episode, because it was the peer support groups that brought me out of my emotional and mental funk. Because as you
Right.
said, you don't want to be alone, and we aren't alone. We just don't realize
No.
how many of us are out here, and Sepsis Alliance is providing this wonderful setting where we can connect through Sepsis Alliance Connect with each other and meet each other. I mean, I love the people I've met in the online support groups and, working with everyone. So as a survivor too, I can't stress enough that really everybody, I don't think you should wait until you have an infection to go on sepsis.org and read. Read about it
Right.
now. Read about it now
Yeah.
when you don't, it's a lot easier to educate yourself about something before it becomes a critical healthcare crisis that you're
Right.
trying to
Right.
manage.
And 1.7 million people per year.
There's a
One of
lot of them.
the Yeah, I think one of the things we talk about in some of the community presentations is I'll tell patient or I'll tell the audience, look to your left, look to your right. One of the three of you will be directly affected by sepsis. And that could mean, one of your loved ones falls ill, you fall ill, a friend, a family member. And that's why I feel like being aware of the signs and symptoms is just as important as knowing CPR and the Heimlich maneuver. These are
Thank
all
you.
very important
Yes.
skills, yeah, that you should have, just to, or basic first aid. I was out for a run this morning and, I'm helping an elderly man who fell off of his bike, so it definitely, and way to go for him being 85 and still on a bike,
Right. Right.
Yeah, but I think definitely trying to figure out how you can communicate your story effectively to providers is vital. I mean, humans by nature are storytellers, and having that ability to say, I was last well when I got this scrape on this day. My tetanus is up to date, but then I noticed that the scrape started turning red. I tried this medicine. I tried that medicine. I got a fever, so that you're able to tell this story because sometimes when patients come in, it's a little bit like the movie Memento. I don't know if you remember that movie, but when someone starts in the middle of the story and then you're like, wait, let's backtrack a little bit. The other thing I recommend is if you do have an infection, that you take a photo of it, and use kind of a standard size instrument next to it, like a pen. That's a standard size. A Sharpie pen is kind of a classic, or a quarter. Probably not a penny since they're soon going to be out of distribution. It takes 3.5 cents to make each penny these days. It makes sense, but
Yeah.
I'll miss it. You
Yes.
know, yeah,
Yes, but I would see, especially doing miniatures when I was younger with my daughters, and people would often use a penny for size
yeah,
comparisons. But
yeah,
that is
yeah,
excellent advice, especially for cuts and scrapes. Or, for
yeah.
example, if a woman gets a lot of UTIs normally, but there's that
Hmm.
one UTI that is like, would she need to be able to communicate to her providers why, yes, I know I've suffered 10 UTIs in the last 3 years, but this one is different, and here's how.
Yes, I think that's very important. And, one of the challenges we face is, as a woman stops having a regular menses each month, and her hormone levels dip down. There's less moisture, down in that direction, and the dry skin is a much easier attach point for this E. coli because you're not constantly lubricating down there. And so it's much more common after menopause to get frequent urinary tract infections. Um, they have found that if you're on an estrogen patch or you're on an estrogen suppository, that can be protective.
Right.
Um, uh, I have had urologists recommend D-mannose, which is a supplement to help with trying to prevent that E. coli, the sneaky little bugger that it is, from attaching to that bladder wall and kind of hanging out there. Because the challenge that we face is that the more times that you have a urinary tract infection, there's more opportunity for that antibiotic resistance or antimicrobial resistance, that AMR, to develop. So one of the key things, if you're in that situation, is to make sure that the provider knows that you frequently get urinary tract infections and to see what the last urine culture showed.
Mhm.
Now, the challenge is that a urine culture, a blood culture, whenever we use the word culture, that
Mhm.
means that it's not in an immediate test result. That will take, 1 to 2 to 3 to 4 days to get the result back. The first step is that the culture will typically show what class of bacteria,
Mhm.
and then the next result will be the name of the bacteria, the specific species. And then the next result will be what that bacteria is resistant to and what it is still susceptible to. So if this is another good example, Jackie, that you bring up, is if you go in and you say, look, I get urinary tract infections all the time. This feels different. I'm nauseous, I'm vomiting, I'm having horrible back pain. Normally it just stays in my bladder, and they're still saying, wow, all the numbers look great, we're going to put you on this antibiotic. The key thing is to see what the response is to that antibiotic. If you're vomiting and you can't keep that antibiotic down, then you're going to fail that antibiotic treatment.
Right.
So in that case, it would be important for the doctor to make sure, or nurse practitioner or PA,
Mhm.
to give you an anti-nausea medicine to help you keep that medication down.
Right.
Then the other thing is making sure you're taking that antibiotic appropriately.
Mhm.
If it's supposed to be twice a day, you take it twice a day. If it's supposed to be 3 times a day, you take it 3 times a day.
And take
Because
the
if you
full course, correct?
Right, right. And
Yes.
typically, if we're dealing with someone who's got a history of urinary tract infections, they get them frequently, you may find that your provider puts you on a longer course than is typical. So typically, if someone has a straightforward urinary tract infection, they
Mhm.
may be fine after 3 days of medication
Right.
you know um, but sometimes we'll put people on longer courses, or if you're getting infections that frequently, some urologists, some primary care doctors, so urologists specialize in your urinary tract system. Nephrologists also do, they take care of the kidneys, so nephrologists typically deal with someone who is going through dialysis. um, but they will want to make sure that you are on the appropriate antibiotic, and they may decide that you are getting infections so frequently, we need to put you on a preventative antibiotic every day. So you may see that they recommend that. And that is why it's so important to know your history. So please take advantage of the fact that we have these apps that allow us, to have my chart or my health online. And even if you're not, technically savvy, then pass the baton to someone who is more technically savvy and have them help you with that, because those that my chart or that my health online is extremely helpful. The hospital that I work at is right next to San Francisco Airport, so sometimes when patients come in, I know nothing about them. They're getting off of an airplane from Baltimore, Maryland, and being able to access their chart is super helpful. But sometimes there is a delay in getting those electronic health records to communicate. So
Mhm.
if the patient can look up on their phone, oh, yeah, my urine test 2 days ago is this result. Oh, my urine culture showed this, boom. And then we can say, oh, well, the reason you're feeling worse is the antibiotic that they started you on, that bacteria is now outwitting it. So I need to switch you to a different antibiotic.
Right. Because antibiotics are not a one size fits all. You have to know what you're
No,
dealing with and know what type of an infection to know what antibiotic is the most appropriate to use in that
right.
setting.
So
So,
oftentimes it'll vary from region to region. So what we'll do is we'll look at the susceptibility for bacteria in um, my hospital versus Johns Hopkins, for example. And that susceptibility chart can be very different. I used to joke around that, uh, it's It's kind of like managing constipation. If you go into a hospital in New Orleans versus San Francisco versus Baltimore, you might get three different ways that people manage your constipation issue. And so the same thing holds true with a urinary tract infection. There might be a different antibiotic that the doctor decides to start because that's what they know that the bacteria in their area is typically susceptible to. And that's why it's so important if you're not feeling better, that you follow up because we may have started with the most common antibiotic for urinary tract infection, for pneumonia, whatever, but you may have a sneaky critter, a
Mhm.
sneaky bacteria going on in there that requires something else. Or, you may have a rarer infection like a fungal infection, so those and antibiotic will not work for a fungal infection. You need an antifungal
Yes.
agent, and that's much, much rarer, you know. And I think the other key thing that we need to point out, just like we talked about that in terms of which antibiotic to pick, is the cause or the infection that is triggering sepsis can be very different depending upon where you live in the world. Sub-Saharan Africa, the most common cause of sepsis probably there is diarrheal infections and malaria. And malaria is caused by a parasite. You get that mosquito bite from an Anopheles mosquito, and it injects that tiny little parasite in you. So, an antibiotic that you would take for an infection in the United States is not going to work in that situation. So, that's why it's so important for clinicians to not only think about, what risk factors someone has in terms of their immune system and their age and what the likely source is, but travel history. So if you are one of those folks who has just gotten off the airplane, landed in San Francisco after an awesome time in South Africa, but you failed to mention that you were on a trip to, sub-Saharan Africa, it's going to change what my concern level is for the most common causes.
Right. Right.
Yeah.
Dr. Molander, you have given us so much wonderful and valuable information. And I know I did want to even delve into where the research is going, when it comes to sepsis, but I think that's definitely going to be for another visit back with you because
Oh,
a lot of
happy to.
people do ask me that too. They're like, but are researchers doing anything about it? Are they discovering anything new? And you and I both know there are some things that are coming out that
And
deserve
maybe
another whole discussion.
Well, and I think if you go to the sepsis website, you'll also
Yes.
see that some of these newer diagnostics that are out there, and we do hold teaching webinars
Yes.
for the clinical community that talk about some of these tools that
And those
exist.
are
And
free, right? The teaching
yeah,
webinars,
yeah.
yes, they're totally free, and you can get continuing education credits, correct?
Well, right now, nurses can get continuing
Ah,
education, but we
yes.
are working on getting continuing education for physicians as well. That's a little bit more of a laborious process, but
Yeah.
I do think it's important that things are happening so fast in the sepsis space right now that, what in terms of new diagnostic studies coming out, in terms of the use of AI
Mhm.
and being able to delve into that electronic health record and pull out the fact that someone had their spleen removed 30 years ago, and the patient totally forgot about it, and knowing that a person who's had their spleen removed is at higher risk of certain infections. Again, that changes my differential as a clinician. And if this is something hiding in the chart, from 30 years ago, it makes it quite difficult. So some of these electronic health records are super slick, that are able to tease out some of that information rapidly, to say, you should be concerned about sepsis in this patient. There are definitely some tools out there. Unfortunately, they're not yet perfect because sepsis is just so challenging. It can be like we talked about earlier, the punky child who's just not feeding well, versus, the person with rip-roaring right-sided back pain and a fever versus, the elderly person who's acting confused, who is vomiting, So definitely trying to come up with some, knowing the patient's past medical history, getting that into my hands more rapidly is going to help me out. And if that means that it's coming from a family member, great. If that means it's coming from their phone and their My Chart online, if that means that it's coming from one of these awesome AI tools that is gleaning kind of their most recent urine culture from 3 months ago when the causative agent, um, uh, definitely, I think we're going to see a lot of change happening. And helping put patients at the forefront there. So again, that they know their vitals, they know they're normal, and they can clearly express their normal, or they have a family member or friend who can clearly express their normal is really, really important.
That is such wonderful advice, Dr. Molander.
Oh,
And yes,
I just want to say, and then the most important thing, there are some wonderful vaccines out there. I know we're dealing
yes,
with some challenging thoughts about the world of vaccines.
right.
And, we definitely don't have smallpox anymore. Smallpox killed thousands of people before the smallpox vaccine came out. Um, and, vaccines can be very, very beneficial in certain situations. And I think you definitely need to talk to your primary care doctor to see if you're a candidate for certain vaccines. Um,
I did
because,
just get my MMR booster because my
perfect.
primary care doctor, I'm 62, and I know I got vaccinated when I was younger, but I couldn't, I, of course, wouldn't know what kind of vaccine. And I heard that in the beginning of the MMR vaccine, it said it might not be as potent. So I just asked my primary care provider to check my antibodies. And she
Yep,
did. I went to the lab, I had the blood draw, and they were low. So I went and got a booster. And, you know,
perfect.
so it, what you're saying here right now is very, very important. I'm sorry for the interruption, but I did have to add that. Yes,
That's a
the
great
MMR, we
example.
even have MMR boosters out there for people as old as me if your antibodies aren't where they should be.
Right, right. And again, because infection prevention is sepsis prevention, you
Yes.
know?
Well, I think that what I want my listeners to, one of the things I want them to gain from this, and there's so much that they can learn from this discussion, but we really are, as patients, we need to be responsible for knowing our own health histories. We need
Yeah.
to know as much about our health care, as we can so that we can help you, the providers, when we're in that critical situation to give you as much information to be the detectives that you need to be, especially when it comes to sepsis diagnostics.
Right.
Would you like to also leave our listeners and viewers with a few key takeaways that they should definitely remember?
Well, I think, infection prevention is sepsis prevention. And we do have a saying that we use called TIME, which is temperature, infection, mental status decline, and extremely ill. So again, TIME as signs of sepsis or symptoms of sepsis to watch out for. Because oftentimes that confusion can be an early sign that someone is getting ill. And the number of times I've had patients with sepsis come in saying, I just feel like I have the worst flu ever, or I have never had pain this severe, especially in a patient who's got chronic pain. I remember vividly someone with a shoulder infection, and she's like, I have chronic pain in this right shoulder, but I have never had pain like this in the past. And that is extremely helpful for me. And again, please bring someone in with you who can be a kind and thoughtful patient advocate. We are human, so yelling at us using profanity does not help. I'm in there with you. I know this is frustrating for you to wait 5 hours to be seen or 6 hours to be seen, um, but we are trying our best, to try and give you the best care that we can. And it is so helpful if you are there with a loved one that you can not only communicate effectively for them, but
Mhm.
support them as well. You
Yes.
know, if you are riling up the team,
Mhm.
including your family member, that's not going to help matters either,
Right.
you know?
Right.
So definitely write stuff down too.
Yeah.
You know, write down the name of the primary care physician, the medications, the allergies. Write down the names of the folks who are coming into the room
Mhm.
because sometimes we're all in scrubs at these point, you know, because white coats carry so much bacteria on them. So, you
Mhm.
know, you might not know who the physician is. So making sure that the clinicians correctly identify themselves,
Mhm.
that you correctly identify yourself. I am the neighbor. I am the nephew. I am the son who has durable power of attorney for healthcare. And right while you're waiting for some of these lab tests to come back or whatever the case may be,
Mhm.
write down your questions. You
Right.
know, make sure that you are getting your questions addressed
Mhm.
and, you know, ask the nurse, you know, can you go through the discharge instructions with me? I want to make sure I understand. There's something that we call the teach back method. So if you feel like something is not being conveyed to you clearly,
Mhm.
you know, say, hey, can we wait a minute? I'm not understanding that. Can I repeat this back to you? You know, I want to make sure I understand, you know.
That's an
Those are
excellent
those
strategy.
yeah, those are kind of the key things.
And when I've been in the hospital at any given time, my nurses and my providers, it really, like, I have experienced it as a teamwork thing, whether the nurse is assisting me to go to the bathroom and and I'm so weak, and I think that's when I could really see their compassion come out because the nurse has got to do some
Yeah.
stuff with us that's, oh my gosh,
Yeah. Yeah.
it's not a regular
Yeah.
person can do that or what you doctors do. And so that's how I kind of see it.
Other thing is, going back to those clinicians, you know, we just like it fills our cup so much to see like wonderful success stories like you. Like Katie Granger, one of our friends who
Yes,
also helps us out quite a bit on Sepsis
Katie's so
Alliance.
amazing.
Yeah, you know, it makes those long days worth it
Yeah.
in the emergency department. You know, it definitely knowing that you there are times where we're exhausted or hungry or really need to go to the bathroom and
Yes.
we're at that bedside trying to help somebody out, you know, and that definitely fills our vessel. So thank you. I'm glad you wrote that
Well, know that
Substack
we
piece
do
because
appreciate you.
yeah, you know, it's you know, I weep for the people who are having a challenging time, you know. I think a lot of it is if we could slow down and try and work on communication. It's just that we are so short on beds in the emergency department, and it's hard to tell your story when you're in a hallway bed and you've
Yeah.
got 35 people around, you know.
Oh, keep fighting the good fight, Dr. Molander. I know that so many of us appreciate everything that you do, especially as emergency room physicians, which is, I think, one of the toughest fields of being a medical provider has got to be. And, I really, really thank you for, taking your time out of your busy day to be on here to help our viewers and our listeners to understand more about sepsis and the ways to treat infections or prevent infections. I think we are in an exciting time with sepsis where awareness is increasing and education is increasing. And one of the ways you can learn a lot about sepsis, even if you haven't experienced it yourself or a family member, go to that sepsis.org website. If anything, just for medical curiosity, and check it out and check out all of the programs and all of the information that's on there so that if you do have a problematic infection sometime in the future or a family member, maybe that little bit of knowledge or something that you read on there might be enough to trigger you to remember this conversation. So,
Please, yes. And let us know at sepsis.org because we love getting these stories. We have over 1,000 Faces of Sepsis stories. So we love hearing about people who knew the signs and were able to intervene early. So It's a small ragtag team that does a great job. I'm very proud to be a volunteer for that organization, because this is something that I'm quite passionate about. And Jackie, I'm so grateful that you're doing this podcast today.
Thank you so, so much, Dr. Molander. It's been a
Oh, it's great to
wonderful
see you. I'm
experience.
so happy you're still with us 4 hours or 4 years after that horrible endeavor, you
And you
know.
as well. I'm
Um,
so glad everything worked out for you and
yeah,
your baby, who's
yeah.
now 25.
And over 6 feet tall. Yeah, kind of
Yes.
wild. Yeah. Okay. Well, very good to see you.
Yes.
Thanks so
Thank
much.
you.